Hello, today we're discussing aortic valve disease. We're going to start the discussion by going over the most common cause, most common congenital condition, um, basically bicuspid aortic valve. Bicuspid aortic valve is the most common cardiac condition, affects 1 or 2% of the population. Um, there is a jet that is eccentric, goes and remodels the aortic root, causing aortic dilatation. Therefore, there's an echo mandate to assess the first degree relatives or patients with bicuspid aortic valve. Now, the bicuspid aortic valve has different anatomic subtypes as shown in the images, and depending on these subtypes, whether someone can have TAVR or not would be decided. Now, this slide here illustrates the dilatation of the ascending aorta that happens in patients with bicuspid aortic valve. Additionally, the classic symptom triad in patients who have aortic stenosis is angina, syncope, and congestive heart failure. Further, some patients present with destruction of the von Willebrand factor due to turbulence at the aortic valve level. This leads to increased tendency to bleed, so they may present with GI bleed. So if you have a patient with GI bleed who has an ejection systolic murmur, consider severe aortic stenosis. Now, on physical examination, the features of aortic stenosis include a slow rising pulse. So it takes a longer time for the pressure to build up enough to push the valve open. Therefore, the pulse is slow rising and it's low in amplitude. This is one of the most important signs of severe aortic stenosis. If somebody has a good volume pulse and has severe aortic stenosis concomitantly, they typically have aortic regurgitation with it, or they have IHSS. Now, going to the murmur is there'll be a gap after the first heart sound, because remember, it takes some time for the pressure to build up to open the valve. After that, the murmur is diamond shaped, rapid up and rapid down, and there's a gap after the end of the murmur and the second heart sound. Further, the second heart sound is softer because the aortic valve doesn't move as much. The A2 component is soft. So these would be all the features of aortic stenosis. Now, if you consider dynamic versus fixed obstruction, dynamic obstruction is caused by IHSS, fixed obstruction by aortic stenosis, and if the cavity size decreases, then the IHSS obstruction worsens. Now, you can do different maneuvers. A Valsalva decreases the preload. When the preload decreases, the severity of the aortic stenosis murmur decreases, whereas the severity of the IHSS murmur increases because the LV cavity size decreases. When you squat, you increase both pre and after load. What happens in this situation is that the aortic stenosis murmur would increase, whereas the IHSS murmur would decrease. Now, a hand grip, which predominantly increases after load, decreases the severity of both the murmurs. Now, moving on to aortic regurgitation. In aortic regurgitation, the problem is the aortic valve might be fixed, therefore doesn't close, therefore blood leaks back in diastole. This leads to a diastolic murmur. Then, if this jet hits the mitral valve, moves it anteriorly, the flow of blood from the left atrium to the left ventricle is turbulent in diastole. So there would be a mid-diastolic murmur like mitral stenosis, known as the Austin-Flint murmur. Because of the volume overload, the pulse pressure would be broader in patients with aortic regurgitation. So they would have an early decrescendo murmur, left lower sternal border, and a bounding pulse. Now, moving on to investigative capacities that we use, transthoracic echo is the first step. This tells us about structure, hemodynamics, and is good for surveillance. Then, when the transthoracic window is inadequate or endocarditis is suspected, we move on to TEE. TEE also allows good characterization of the aortic root. If the TE is inadequate for this, cardiac MRI is a gold standard for assessing the root. Cardiac CT is playing a bigger role, particularly in patients with TAVR. The calcium score of the aortic valve helps decide the severity, with more severe aortic stenosis having a higher calcium score. This is of particular importance in patients with low flow, low gradient aortic stenosis. Now, as we know, the ACC AHA has the A, B, C, D, A being at risk, B being progressive, C being asymptomatic severe, and D being symptomatic. So stage A at risk would be bicuspid aortic valve or patients with aortic sclerosis, with the Vmax across the aortic valve being less than 2 meters per second. Stage B is mild to moderate aortic stenosis with the velocity 2 to 3.9 meters per second on echo, patients being asymptomatic. Stage C is those patients who have severe aortic stenosis where the EF is normal, the Vmax is greater than 4, but they have no symptoms. Or they have C2 class where the EF is depressed. Stage D is severe symptomatic aortic stenosis. These patients have a high risk of death and should be treated quickly. There is yet another category called low flow, low gradient aortic stenosis. The flow across the aortic valve is reduced, and because the stroke volume is low, the gradient is low. This can be paradoxic, where the ejection fraction is preserved, but the stroke volume is low and the gradient is low. In these patients, you can either use a dobutamine stress echo, a dobutamine heart catheterization, or a CT scan, where the calcium score helps us assess whether the aortic stenosis is severe or not. Now, there are patients with mixed aortic valve disease, where they have both aortic stenosis and regurgitation. The valve is stuck open and stenotic. In these patients, there's a pressure and a volume overload. There's accelerated LV decomposition. Now, you should intervene in these patients and you rely on velocity rather than pressure. The increased blood flow across the aortic valve can artificially increase the transvalvular gradient in these patients. Now, treatment modalities include surgical aortic valve replacement, the gold standard, TAVR, the new kid on the block. Surgical aortic valve replacement is a permanent solution. It involves a sternotomy. You typically use a mechanical valve because of its durability. It's typically used for patients with more than 20 years of life expectancy or age less than 65. For those who are 80 or over or less than 10 years of life expectancy, we do TAVR. For the in-between patients, 65 to 80, then this is an individualized decision. Now, there's a new kid on the block called RAVR, robotic aortic valve replacement. In these patients, a right mini thoracotomy is done. The robot accesses the valve through that plane, and then you replace the valve. Now, if you have concomitant coronary disease, the treatment choices would include open sternotomy, bypass surgery with surgical aortic valve replacement, or percutaneous intervention of the major coronary artery, along with TAVR or RAVR. Excuse me. Prosthetic valves can be bioprosthetic or mechanical. Bioprosthetic valves typically are chosen for older patients or those in whom oral anticoagulation is contraindicated. They typically last 10 to 15 years. Mechanical valves are permanent, shall we say. They require vitamin K antagonists, usually high intensity. There is a valve called an on-X valve, which is an exception, and on account of the material used in the valve, you can use a lower INR, 1.5 to 2.5, and decrease the risk of bleeding. Now, in patients who have native aortic stenosis with AFib, you can use either the novel anticoagulants or warfarin. In patients with bioprosthetic valves, novel anticoagulants are safe more than 3 months after implantation if patients have AFib. In traditional mechanical valves, novel anticoagulants are contraindicated due to risk of thrombosis. The Onyx valve, as we discussed, allows a lower INR, 1.5 to 2. Okay, now what to do if a patient has a faint murmur and you're suspecting aortic stenosis? Remember, the murmur would be faint if they have LV dysfunction. Then you rely on the carotid stroke or the femoral upstroke or the brachial. In severe aortic stenosis, it's a delayed, slow rising pulse. If patients are symptomatic, this dictates survival. If they are asymptomatic, they live for a fairly long time. If they are symptomatic, then action needs to be taken quickly. Now, it's important to differentiate low flow, low gradient aortic stenosis from, shall we say, pseudo AS. And we discussed the use of dobutamine stress echocardiography and calcium score on CT. Now, mechanical valves are a definite contraindication to novel anticoagulants. And remember to screen the family in patients with bicuspid aortic valve. Thank you for listening. More to follow.